Everybody knows what this is, right? It's the Golden Gate Bridge over San Francisco Bay, right? Okay, this is the most famous bridge in the world. This is the Brooklyn Bridge. And I would remind you, as I've done for the past 17 years, that we are like the two people on the catwalk. And on one side is Brooklyn and basic biological science. And on this side, the New York side, is clinical medicine. And the whole purpose of the course is to get people to talk together across these disciplines and to help build some bridges. So we're all in the bridge building business. And today is a marvelous example. Another one. Each week is, as illustrates the point. But today the topic is diabetes. For those of you who are interested, the word is ancient and it means passing through. The recognition that diabetic patients were urinating a great deal. And in the beginning, it was a fatal disease, uniformly fatal. In 1921, insulin was discovered by Banting and Best. That introduced a whole new chapter. There is now some therapy, and that led to the classification of type 1, type 2. Some people are insulin resistant, some aren't. And there have been major developments throughout the years in insulin signaling. How do you measure glucose in an effective way in a patient? Insulin types, dosing, delivery, and a whole bunch of biology. However, despite all of this, diabetes is still the 7th major cause of death. So why is it? And where do we stand? And so today's speakers are going to address that and other aspects. So I want to, before, ask a quiz. What do these things have in common? What? You have to speak up. Well, I can't hear you, but if you said they have artificial sweeteners, you're absolutely right. and that's going to be the topic which our second speaker is going to address. So our first speaker is Phil Gorden, who got his medical degree from Vanderbilt University, trained in medicine and endocrinology at Yale, came to the NIH in 1966 as a clinical fellow. His work at that time was extremely significant because that was one of the heydays of the development of understanding of insulin, mechanistically, how it works, the insulin receptor, and Phil was very, very much a part of all that. He spent a year in Switzerland with Lelio Orci doing electron microscopy of some of the aspects of the receptor-mediated endocytosis pathway he was interested in, and then came back to NIH as a major branch chief, and then a clinical director of the NIDDK from 1986 for 13 years until 1999. He served as director of the NIDDK, and during his tenure, a series of remarkable, significant clinical studies were performed, which examined attempts to prevent diabetes, to control diabetes, and so forth. In 1999, he returned full-time to the intramural program, where he has continued to focus on mechanisms and on therapies. Now, our second speaker, Kristina Rother, received her medical degree in Freiburg, Germany. She also took a degree at Duke University, a medical, what is it called, a master's in health sciences, a special course. And then she spent a residency in pediatrics and in endocrinology, essentially by bouncing between the Mayo Clinic, the Children's Hospital in Zurich, the Massachusetts General Hospital, then back to Zurich, where she was a visiting scientist in molecular biology, came here in 1998, And she is a clinical investigator, a section chief in charge of the section on pediatric diabetes and metabolism. Her work is increasingly well known, particularly because of her focus on some of the issues that are represented by the artificial sweeteners. So, Phil, would you begin, please?
Thank you very much, Wynn. Is this volume and so forth okay? I didn't turn it on. I know it's not okay. Okay, is that better? Is that okay? Well, I can actually talk louder, but I can't talk any faster. So I can't give you a New York accent like Dr. Arias' slide here. There's no way that can happen. What I wanted to do, because of the nature of this gathering, and I have to admit I'm a little bit nervous because one of my former mentors, Dr. Jan Wolf, is here, and he always makes me a little bit nervous when he's in the audience. He asks sometimes difficult questions. So what I wanted to do was go through a few principles. Generally, in clinical medicine, we start out with a kind of a broad generality, and we try to narrow it down to something relatively specific. And so the title of this is really what we're aiming towards, not necessarily where we are. So we're trying to get essentially from here to there by going from the general to the more specific. So let's look. Frequently, when a patient comes in to talk to you, they want to know if my disease or my condition can be cured. And so let's just look for a minute at the concept of a cure, because this is really a very important issue. And one example will be pneumococcal pneumonia. And penicillin turned out to be a dramatic and really complete cure for pneumococcal pneumonia. And then we come to things like vaccines, where we've eradicated a lot of diseases with vaccines. And so this is another form of a cure. And then we come to something like duodenal ulcer. And this is a specialty in gastroenterology, Dr. Arias' area, but let me just comment for a minute. When the H2 blockers, proton pump inhibitors, many of you take some of these pepsids or these various antacid preparations, these were used actually to treat peptic ulcer disease, which is a very common and devastating problem for a long time. And it could be assumed that this, not assumed, but this was related to hyperacidity of excessive gastric acid production, and these things would sort of neutralize gastric acid. But when you stopped them, it all came back. And the problem is that we didn't know it at the time, but the reality of it was that we didn't understand the etiologic basis for this. And then comes along a discovery of a bacteria, H. pylori, which turns out now to be the etiologic basis for peptic ulcer disease. And now we can go through a series of antibiotic therapies of various types and completely cure this process. We can do it because we understand the etiologic basis of the process. That's what we're aiming for. Now, so here's where we are trying to go. Now let's look at three of the major conditions that lead to the greatest amount of morbidity and mortality in this country and indeed all over the world. Hypertension, dyslipidemia, and diabetes. These are very, very prevalent, but unfortunately, the etiologic basis for these diseases, all of them, are only known in maybe 10 to 15% of the cases. we do have, fortunately, carefully controlled clinical trials using very nonspecific types of therapy that can control these conditions. The first that sort of yielded was hypertension. This goes back into the 50s when controlled clinical trials were done to show that you could actually reduce the morbidity and mortality of cardiovascular disease by treating hypertension. Then later in the 80s came the dyslipidemias, cholesterol, etc. Diabetes lagged behind, but in the 90s, we actually were able to show that the major morbid features of diabetes, which are generally referred to as microvascular complications, that is, the complications of the eye, it's the leading cause of blindness, the complications of the kidney, it's the leading cause of end-stage kidney disease, and the complications of the nerves, the neuropathy, can actually not be cured, but they can be ameliorated and markedly, the prevalence can markedly be reduced by appropriate treatment. However, we're still sort of searching for an etiologic basis because with diabetes, and here's the classification that Dr. Ayers was referring to, type 1 diabetes that Dr. Rother can tell you more about later if you have questions, counts for maybe 5 to 10% of all diabetes that we see. Type 2 diabetes, which is the way it's classified, is really the adult form of diabetes, actually is now seen, unfortunately, very prevalently in children, which is really unfortunate. But it is the common form of diabetes that's associated with obesity and other metabolic disturbances. This counts for probably 90%. Now, what we're going to basically focus on here are what's referred to as other specific types of diabetes, meaning that there's a collection of conditions. Some are genetic, some are acquired, some are other. They're relatively uncommon, maybe accounting for only 5% of all cases of diabetes. But because of the severity of these conditions, it offers us an opportunity to actually understand the etiologic basis and develop what was shown on the first slide, some sort of precision type of therapy. Gestational diabetes is very specific. It occurs during pregnancy. We won't really cover that. Now, what I've essentially said is that we're reaching from relatively common disorders, the so-called metabolic syndrome, which is when we combine hypertension and dyslipidemia and obesity and type 2 diabetes all together. We refer to it as the metabolic syndrome. Actually, it was described a number of years ago by Jerry Reven, who passed away in the last few weeks, who was just a giant in clinical medicine, referred to this as Syndrome X. And then later some committees, several committees, decided to call it metabolic syndrome. But this is basically what we're talking about from epidemiologic, when you see all these things occur essentially in the same individual. Polycystic ovarian disease, the leading cause of infertility, is another variation which we now know is actually influenced in an important way by insulin resistance, and perhaps has several different causes, but influenced in a major way by insulin resistance, and then type 2 diabetes. Now, what we're going to focus on then is a more severe and the rare types of conditions that allow us or lend us the possibility of understanding the etiologic basis for developing specific therapies. One is called lipodystrophy that we'll talk about more, insulin receptor mutations, and autoantibodies to the insulin receptor. Now, this is A group, lipodystrophy syndromes refer to a collection of different diseases that are characterized by a selective loss of adipose tissue. Can be generalized, as you're seeing here, and it can be partial, as it occurs in where different parts of the body are spared. That is, frequently fat is lost largely from the extremities and maintained in the central core of the body. There are a number of genetic defects that are now known to be related to this, several acquired disorders, and so forth. We don't have time to get into all the details of that. And also this other class of diseases called the insulin receptoropathies. And the insulin receptor is a cell surface protein that was actually conceptualized here at the NIH by Jesse Roth, Ira Paston, and Bob Lefkowitz a number of years ago as a cell surface receptor, which was the first step in the action of polypeptide hormone. Essentially generalized all polypeptide hormones, whether it's insulin or any of the other pituitary or other polypeptide hormones. This is where they first act. We then began to see diseases that are associated with autoantibodies to this receptor. And we then began to see diseases that we suspected were genetic in origin, but we didn't have the tools to actually prove that in the beginning. Later on, it turns out that we were able to show that another class of these insulin-resistant syndromes were truly due to mutations in the insulin receptor. So here's an example of what was actually discovered. The insulin receptor is a cell surface protein. It has, it's a heterodimer. It has 2 alpha subunits and 2 beta subunits. And the alpha subunit is the binding domain of the receptor, and the beta subunit turns out to be a tyrosine kinase. And when insulin binds to the alpha subunit, the extracellular domain, it sets up a series of allosteric changes that allows the contralateral beta subunit to phosphorylate the other beta subunit. So now we have a system of autophosphorylation that now energizes this entire system. So these diseases that I'm talking about relate to either autoantibodies predominantly associated with the extracellular domain, but could be with the intracellular domain also, and to mutations that occur in any part of this receptor. And we could go through and characterize these if we had more time, but this is the fundamental. Now, after the receptor tyrosine kinase has been activated, there are a whole series of steps that occur downstream of the receptor. And interestingly enough, very few mutations or other abnormalities have been associated with diseases. The majority of what we see in terms of disease are associated with this insulin receptor cell surface protein.
One question. Where is the epitope of the autoantibody? Is it identified on the
There are many different epitopes. There's a whole series of classifications of what those epitopes are. But there are many different ones. It would be hard to describe it briefly. So what we're going to do now is look at sort of 3 stories in terms of how we might approach these diseases by understanding the etiologic basis and developing some specific therapeutic strategies. So we're going to look at these 3 different phenomena here. So first, let's talk about the development of a new technology. So here's a young woman who has lipodystrophy, and it's very clear that she has a paucity of fat. You can see this. She has a deficiency of the adipocyte hormone leptin, which we're going to talk more about. She has insulin resistance. She has hypertriglyceridemia that you can actually see in her skin. What you see here with all of these red spots are what's called xanthomata, which are deposits of triglyceride that are occurring everywhere. And in a sense, she had them on the soles of her feet to the point where she couldn't even walk. They were so painful. And they get massive fatty infiltration of the liver, which leads to a very severe form of liver disease, which we know is NASH, or non-alcoholic steatohepatitis, which can lead to cirrhosis, may actually turn out to be, once the viral hepatitis, is hepatitis a correct word, or hepatitis? I don't know what the plural of it is, but once the viral diseases of the liver are controlled, this form of liver disease may turn out to be the leading cause of end-stage renal liver disease. Anyway, you can see that this is a pretty bad situation. So the story of how one began to approach the treatment of this begins with this mouse called the OBOB mouse. Mark Reitman knows this mouse. He studied it in great detail and made some really beautiful observations about it. But this is an obese mouse that was characterized by Doug Coleman, who did some cross-circulations to normal non-obese mice and found that if he did cross-circulation, he could make this mouse thin. And basically, he basically formulated the thesis that there is almost certainly a circulating molecule of some kind that is controlling satiety, that is basically the energy regulator. It's the thermometer of energy balance. However, he was not able to actually characterize this in further detail other than to say that it must be there. Along comes Jeff Friedman at the Rockefeller about 22 years ago, and he actually discovers the genetic mutation in this mouse and gives the protein the name leptin. And it turns out that this fulfills all the criteria that Coleman had postulated. It is the major hormone regulating energy balance. The plasma leptin concentration is a function of adiposity. This is very surprising because we don't think of hormones being made by fat cells, but it turns out that many hormones are made in fat cells, and this was one of the first to be discovered. So you can imagine now what happened. If you have something that controls satiety, we have the magic bullet for treating obesity. I mean, it follows. A fortune was paid to the Rockefeller by Amgen to produce this product, which obviously they knew the structure, they could make all that they needed, did a huge clinical study of treating 1,000 people or so. And basically, what did they find? They found that it didn't do anything, or it did almost nothing. Why is that? Well, if they just thought about it a little bit, they would have understood that the hormone that they were giving, the biologic they were giving, was a hormone that was produced by fat cells. And if you've got a lot of fat cells, it's pretty likely that you got a lot of the hormone. And it turns out that that was true. So leptin is kind of secreted constitutively. You got a lot of fat cells, you got a lot of leptin. And there's a general principle of endocrinology that probably is relevant to a lot of other fields too. But it says that if you got a lot of something and you give more of it, it doesn't do very much. And actually, that's probably true in politics too. I haven't really thought about that, but think about that just a little bit. At any rate, this was the state of this, where it looked like this was going to kind of be the end of the story. An incredible scientific discovery, but the sort of end of story for the fact that this might actually be efficacious in some other way. So it's made by fat cells, as we said. There's a number of other adipokines that are made by fat cells. Now, the question is, how do we take leptin from hormone to a major pharmaceutical? And this happened in 2 stages. The first stage was studies that Mark Reitman did here characterizing leptin in this mouse model, in a model of lipodystrophy, actually. And it was also characterized in this OB mouse. Basically, it was also Brown and Goldstein also had a mouse model that could demonstrate that if you don't have fat cells, that is, this is the situation of low leptin concentration. The general principle of immunology, of endocrinology, that if you don't have something and you give it, it may work. Hypothyroidism is a classic example. Give thyroid hormone to someone with hypothyroidism, it cures them. Well, anyway, this is basically the idea. So this is what happened on the human side. On the mouse side, it was shown that if you give leptin to this OB mouse, the OB mouse became thin. And this was essentially reproducing Doug Coleman's experiment of cross-circulation. This is exactly what happened. And O'Reilly and associates, Faruqi and associates in Cambridge, did the same thing to some children with this OB mutation, the same mutation in the mouse that was occurring in human. These were massively obese children. And if you gave them leptin exactly the same way as the mouse, they became thin. So now the question was, what about lipodystrophy? We had patients with this condition. We'd been studying for years for other reasons. These were individuals who had low leptin concentrations because they didn't have fat cells. So this was really what the question was. So here's an example. 21-year-old young woman with generalized lipodystrophy, poorly controlled diabetes, diabetic ketoacidosis, severe hypertriglyceridemia, and very severe protein in the urine. So you can see that when this patient was given leptin, that there was a marked improvement in hemoglobin A1C, which is another measure of chronic glucose. Insulin dose went from a very large amount to nothing. Triglyceride levels fell from huge levels, the upper limit of triglyceride being around 150 of normal. These were 6,000, down to 179. And urine protein excretion fell from what's referred to as the nephrotic range down to almost normal levels. So leptin then was having a dramatic effect in this particular condition of lipodystrophy. And this is this young woman that I showed you before when she was, the young woman that I showed you before who had this severe enlargement of the abdomen, and you can see after leptin therapy, she's essentially lost this huge liver size that was filled with fat. Her skin has essentially cleared of these lipid deposits, and she now has gone from a lipid triglyceride concentration of 12 to 13,000 down to levels that are close to 200 to 300. So it's again a very dramatic effect. Now, then, based on the studies that were carried out here in the clinical center, leptin is then approved for the treatment of lipodystrophy by the FDA for generalized forms of lipodystrophy. So we have a ways to go to include all the patients, but at least we've got the foot in the door here with this beginning form of lipodystrophy. Now let's look at an example of a new use of an existing technology. So this is the patient, 21-year-old young woman, average blood sugar of 371. This is very high. Extreme weight loss, massive polyuria, putting out up to 15 liters of urine a day. Severe skin condition known as acanthosis nigricans, and extreme insulin resistance. In other words, if you give this patient thousands of units of insulin, it had very little effect. And this is what she looked like. This is this condition, acanthosis nigricans. You can see it on her back, her face, her hands, and particularly in the axilla. And so what was done here, and there's so many experts on immunology around, and I went to every one of them I could find to try to get them to help me. All we need to do was to wipe out an antibody. This is produced by a circulating antibody. The antibody doesn't cause any kind of inflammatory condition, doesn't cause T-cell destruction of tissues like type 1 diabetes, doesn't do any of those things. But it binds to this receptor, as I told you, and inhibits the action of insulin to this receptor. And I can only get sort of incremental advice. And so finally, we decided that, well, let's just think about what each of these component things can do. So rituximab, some of you may be familiar with this, is a drug that's commonly used for a variety of immunologic conditions, but particularly for B-cell lymphoma, because it basically will destroy immature B cells. But then if we just gave that, it really had very little effect in this young woman. So what do you do in something like multiple myeloma, where you have all sorts of immunoglobulins produced with resting cells that are not immature? They're just there. So the rituximab really won't touch those mature cells. But if you give high-dose steroids to those individuals, it will affect those cells. And then if you use a sort of a non-specific inhibitor, such as any alkylating agent, cyclophosphamide or cyclosporin, drugs that basically will sort of knock out helper cells, and you combine them, these are principles that have been used in antibiotic treatment for years, or cancer chemotherapy. Everyone tries to use a formulation that will give you the maximum benefit and the least side effects. Well, sometimes you do that by combining drugs together. And that's basically what the principle was here. And so when we did this, we put them all together, we actually could cure this young lady. She has absolutely no insulin resistance. While she was taking 15,000 units of insulin with almost no effect, she takes no insulin at all. We actually now have 20 patients that fall into this category. It's obviously very rare, but it's an important principle. Now I'm going to just show you one more example, the combination of the old and the new. So I told you that there's one additional group of people who have mutations in the insulin receptors. And the question was, well, what might we do for that group of patients? And so we began to sort of think. Now, this is a young man, and he has this, again, this acanthosis nigricans. He has some other features that go along with the insulin receptor mutation, but he has severe insulin resistance. And so the idea was, if we look at the insulin receptor that I'm showing here on this side, this is the alpha subunit, the beta subunit. These are downstream substrates of the insulin receptor. And the one thing that you will notice here is that the insulin receptor and the leptin receptor, leptin being a cytokine, has basically a common pathway at one of its subcellular components, that is at a PI3 kinase step. So is it possible that we could get crosstalk by showing that we could give leptin and binding to the leptin receptor, and that would spill over to the insulin receptor downstream. Well, this was the idea. And the fact is that we did get a partial effect, not the complete effect that I've shown you with the others. So what I've tried to do here is just take you on a bit of a journey from these common diseases, these common conditions, type 2 diabetes, metabolic syndrome, all of these, to these rare conditions where we can now sort of define the etiologic basis, develop some new strategies, and begin to think in the diabetes field of how we might introduce a more personalized form of therapy. And so I'll stop with that.
I would like to ask a question regarding microvascular disease. You mentioned that it happens in diabetic retinopathy, nephropathy, and a few other areas. So what is it, the endothelial cell versus glucose or insulin that might be affecting the microvessels, causing the complications?
As best we know in diabetes, the common phenomenon is hyperglycemia. And if we try to relate that to all these different areas like the eye and the kidney, we have to invoke things like oxidative stress and so forth, with cells taking up glucose because the glucose concentration is high, and glucose then metabolism is leading to oxidative stress. And this is one hypothesis that relates particularly to the kidney disease, but it also relates to the eye disease. And it's really the only thing we can really invoke, in the sense that we know that lowering the glucose concentration will markedly ameliorate these conditions. In fact, all these conditions that I've mentioned here are conditions in which we don't look under a slide and see, well, that's hypertension. We define it by a range of blood pressures. Well, diabetes is defined by a range of glucoses. And we know that when your glucose concentration goes above 126 milligrams per deciliter, that is when you begin to see retinopathy. And that is the definition of diabetes. That's how we define it. And so we know if we can knock those levels down, and we've shown that with a number of clinical trials, that it markedly ameliorates the condition. And then we come into these hypotheses about mechanistically how does that work, and that gets to be a black box very quickly.
I'm diabetic, I'm doing exercise to keep it below 100.
You've got to keep it down.
When I was in medical school about 100 years ago, I had to give a debate on tight control of glucose or not so tight. Today in the Washington Post, this argument has reappeared. What's the current, more scientific thing for very tight control?
Okay, this argument was raging exactly in the way that you say until 1994. In 1994, we completed a major study called the Diabetes Control and Complication Trial. And in that study, we showed that with a 20% reduction in hemoglobin A1C, which was a measure of glucose, of total glucose, you could get very significant reduction in retinopathy. That was the endpoint. That essentially, that study, which was really one of the first big controlled clinical trials of its type, ended that argument, because the argument was based on the idea that if you tried to control glucose levels too much, you got hypoglycemia. And that's what led to this argument. So many people said, well, we don't do a lot of good to get the blood sugar down. So why should we risk hypoglycemia? Well, in the diabetes control and complication trial, we definitely had more hypoglycemia in the experimental group that got the lower levels, but they got this benefit. And so that ended the argument. And so a bit of an argument went on in type 2 diabetes, but even that argument has been sort of ameliorated. And then we have this sort of elephant in the room of cardiovascular disease, because we know that diabetics have 3 to 4 times as much cardiovascular disease as non-diabetics. And what we've never been able to show yet is that this type control actually reduces the rate of cardiovascular disease. The only way we've been able to show it is in the diabetes control complication trial follow-up over many years, where the control has been lost. The group that was in the tightly controlled group have less cardiovascular disease than the original control group. But that's not a controlled trial. And so we've never been able to actually show that. Whereas in hypertension, dyslipidemia, you could actually show effect on cardiovascular disease. So this is sort of something that still has to be done. Okay, I'm going to turn things over to Dr. Rother, and she can answer any other questions that haven't been. One more.
Phil, what is the mechanism of insulin resistance in type 2 diabetes?
Okay, we could go on for not only the rest of the evening.
We need one more hour.
We could go on. So there have been, the only answer that I can give you that's clear cut is what I've shown you. If you have an insulin receptor mutation, that is the cause of the insulin resistance. If you have an autoantibody to the insulin receptor, that is the cause of the insulin resistance. But when we get away from that, which is 99% of the situations, we actually don't know what the answer to that is. We can talk about endoplasmic reticulum stress. We can talk about a whole variety of molecules. We can talk about atypical protein kinases. It depends on which investigator's pet theory you want to invoke. And we can almost kind of turn them inside or around. There are about 5 or 6 hypotheses that go into this, and maybe none of them are really totally relevant, or all of them. It's that kind of situation that is a very important issue. What we do know is that if we can ameliorate obesity, which is a fundamental driver of the insulin resistance, we can markedly improve the insulin resistance. And so we know that exactly why we're doing that. We can actually show modulation of the insulin receptor when you do that. But there must be many other things that are going on that do that. But it's a real issue, and we don't have an answer for it.
Welcome to the entertaining part of this afternoon, namely the topic of artificial sweeteners, on which most people have an opinion. It's almost like obesity. What causes obesity? Are artificial sweeteners good or bad? So I want to start my talk with a quiz. This quiz is based on the EPIC Norfolk study, so that's the European Prospective Investigation into Cancer and Nutrition. This is a large-scale study, more than 30,000 people in the study, and has been widened to also include other topics, not only cancer, but for example, diabetes. And they gathered information on the dietary habits, including the type of beverage that the participants consume. And what do you think? Do sodas and sugar-sweetened milk and things like this do to your risk of diabetes. So on the y-axis, you have the hazard ratio, and as you all expected, it clearly increases the risk of diabetes. Now, of course, the question is, what does diet soda consumption do? Does anybody want to risk an answer? Similar, more or less? Some of you have seen this, and I feel it's quite astonishing, namely that the risk is exactly the same as with regular soda, sugar-sweetened soda. So we'll do this one more time, this time a Framingham study, and you see the N is 2,600 and something, and you may wonder, why are there so few people? Framingham has many more, but on these individuals, there were liver ultrasounds and liver function tests available, and that's why they were included in this assessment. And again, just like with diabetes, the risk of development of fatty liver goes up in a dose-dependent way with the increase of sugar-sweetened beverage consumption. So how does this look like when you look at diet soda? Just looks the same. Very, very similar. So how come? This is the topic of this afternoon. How come that in the, Phil, I'm going to quote you now, when I started all of this research, I remember you asking, now, Kristina, you are aware of the law of thermodynamics. How can something that doesn't have any calories cause adiposity? And this is what I want to try to explain by not violating any laws of thermogenesis. So these two studies, large epidemiologic studies, they both, when adjusting for BMI, showed that actually diet soda consumption became non-significant. And therefore, the authors concluded that diet soda consumption has nothing to do with diabetes or fatty liver disease. And my colleague, Alison Silvetsky, and I, we did not agree with this interpretation because obviously obesity is the central factor in development of type 2 diabetes and fatty liver disease. And so we felt that they were pouring out the baby with the bathwater. So I structure the talk in that I will give some more specifics information about the artificial sweeteners and the sweet taste receptor. Then I'll talk about a few more health outcomes other than just obesity. And ultimately, I want to convince you that there are plausible mechanisms that link artificial sweeteners with these health outcomes. So there are 6 FDA-approved artificial sweeteners. And what does it mean, FDA-approved? It means that the FDA determines, based on toxicology studies, which is the upper limit of daily intake that is assessed or assumed to be without negative health effects. And of course, the FDA focuses on cancer and teratogenicity. And you can see here the ADI, the accepted daily intake, for example, for saccharin with 5 milligrams per kilogram is about 3 sodas a day. Now, you can drink a lot of Diet Coke because that has aspartame, 18 sodas a day. Sucralose, 5 sodas a day. So many of you probably need once in a while some caffeine, mostly caffeine-containing soda. And so can you figure out what your intake is? Intake of artificial sweeteners per body weight, because that's how the FDA regulates it? No, you cannot. This is a food label, an ingredient label here on the side of a soda. And what it says it contains sucralose and acesulfame potassium. Now, most even average educated consumers don't even know what acesulfame potassium is. Also, sucralose is often mistaken for sucrose. Sounds just like sucrose, right? But that's a trichlorinated sugar and is an artificial sweetener. So the problem is that artificial sweeteners are listed on ingredient labels just as being present, but there's no amount. So you cannot figure out whether you supersede the intake recommendations. How are all sweet tastings signaled? Via sweet taste receptors, and at least, again, kind of the historic aspect, you may remember these charts of tongues that had specific colors in specific places, and it said that's where salt is being perceived and that's where sugar is being perceived. That's not true. We have these taste receptor containing cells sitting in taste buds, and they sit in the papillae of the tongue, and they're basically all over the tongue, and in the also pharynx and oral mucosa here. Now, the sweet taste receptor belongs to this 7-transmembrane domain G protein coupled receptor. In fact, these are kind of the sisters here, the sweet taste receptor, the bitter taste receptor, and umami taste receptor, because they all three are made up of dimers. In the case of sweet taste receptors, it's heterodimers. In the case of bitter taste receptors, of which we have about 30, whereas we have only one sweet taste receptor, but the warning of something toxic is probably more important than what contains nutrients. So these G protein coupled receptors are being activated by a sweet tasting that comes on the tongue or in the oral cavity, and is then signaled via cranial nerves, specifically here to the lateral aspect of the brain, the operculum, the insula. What I thought was truly fascinating is that taste receptors obviously are in the oropharynx, but if you look at this fly, you see this fly has taste receptors on the wings, on the feet, everywhere. And how is this with humans? Well, we have them all over the place too. We have taste receptors in the brain, on bone, in the lungs, in the liver, pancreas. Of course, most interesting here is the pancreatic beta cell. We have them in the intestine. I'm going to talk about enteroendocrine cells. We have sweet taste receptors on adipocytes, and some in the audience have them in their testes, and I refer to males and with some. So what about enteroendocrine cells? So here we have an L cell, enteroendocrine cell in the intestine. They have glucose transporters like SGLT2 or GLU2. They also express sweet taste receptors. And when you, for example, via an NG tube, put something sweet into the gut, would you perceive that as sweet? No, of course not. You don't perceive it as sweet, but there is signaling taking place that is very similar to the signaling that happens in your taste buds. And in case of an L cell in the gut, you will then secrete GLP-1. GLP-1, obviously a hormone that we're using in a pharmacologic way as a medication, decreasing gastric emptying, decreasing appetite, decreasing glucagon, and increasing insulin levels. So the stimulation of GLP-1 is clearly something that is being used in the treatment of diabetes and appears to be something positive. In fact, we tried to figure out whether artificial sweeteners do clinically stimulate GLP-1, and in a simple experiment, starting here on the right side, we gave either a glass of water or a diet soda containing artificial sweeteners to healthy study participants, and then we stimulated insulin secretion with an oral glucose tolerance test. So first, diet soda or water, then an oral glucose tolerance test, and what you can see is the red line is higher than the blue line. The red line means pre-treatment with diet soda. So these are the same individuals. They do this on 2 occasions, and their GLP-1 is higher when the pre-treatment is diet soda. If you do this in individuals with type 1 diabetes, you see the same result, a little more marked. So in one case, the area under the curve was 34% higher, and the other one 43% higher. So that sounds like that's great. But we also tried to look at the clinical relevance. So we was just outlining GLP-1 effects. And to our disappointment, when we co-administered the oral glucose tolerance test with acetaminophen, we saw no slowing of gastric emptying. We also did not elicit any change in appetite on a simple visual analog scale after only 1 administration of the soda. So you can say, what is the clinical relevance? Because this is an acute test, we should test this after chronic administration. We didn't do glucagon testing, but others have found no difference. And then insulin, yeah, we saw a consistent increase with various stimuli of artificial sweeteners, but it was not statistically significant. And so I really want to leave this question mark there. Is the bit of GLP-1 increase that we saw, is this really of any clinical relevance? What I want to say is, though, that you need to choose your participants smartly. And Janina Pepino, who worked with Sam Klein, she chose her participants in a study that was done exactly the same way as we did it. First, either water or artificial sweetener, then oral glucose tolerance test. She chose women. These were mostly African-American women. You can see here, obese with a BMI of 42. And in these women, she actually showed a greater increase in glucose and followed by a greater increase in insulin. So it is our interpretation that since we had a wide range of individuals participating in our studies, we had a very large standard deviation of our insulin results. And that probably leads to non-statistically significant outcomes. So the question remains whether susceptible individuals, individuals who already are insulin resistant and now ingest artificial sweeteners, whether they actually may worsen their insulin resistance. So let me get to a few other health outcomes beyond obesity. So for obesity, I kind of count into the realm of obesity, liver, pancreas, intestine, adipose tissue. But what about, for example, the brain? What do artificial sweeteners do in the brain? Susie Swithers, our colleague in Indianapolis, is very convinced that artificial sweeteners actually lead to a confusion, because if you administer them long enough, the brain assumes that sweetness in the insula is not associated with calories. So that concept has only been shown in mice, or better, she does it in rats. Decreased reward is another possibility, and there are some data which I find quite intriguing. So here is a functional MRI where participants receive either sugar, sucrose, or artificial sweetener, sucralose. And you can see if you give sugar, your insula lights up, that's where the sweetness is, and then the center lights up, hypothalamus, dopamine secretion, where your reward is being signaled. How does this look like when you give sucralose? I think this is not a representative fMRI because it looks so clean, because what you see here in the middle is nothing. So that means that there is decreased dopamine, though that's the area in which you would see dopamine activity. You see the sweetness in the lateral aspect of the brain, but you see different activity in the center. So the hypothesis is that You get the sweetness, but without the same reward. So you will keep seeking sweetness, which means you will keep eating. What about the thyroid? So there's a small study in mice that proposes that sucralose administration to mice for a prolonged period of time can lead to lower TSH, basically a sick thyroid syndrome. So low normal thyroid hormone levels and lowish TSH. Now, if this was true in humans, then that might contribute to obesity. The only human data that we have are on autoimmune thyroiditis, and there is the question whether it promotes autoimmune disease. How about bone? This is the latest. So this is a 2018 study, just came out, and I'm glad that it's finally beautifully presented, namely that osteoclasts have sweet taste receptors. So stimulation of osteoclast would then explain epidemiologic findings, possibly, of lower bone mass and higher fracture risk. So the lower bone mass is a study that comes from Irish girls that shows lower bone mass in the kids, in the girls who consume more artificial sweetened beverages. But of course, so there's reverse causality in lots of obesity trials, but there are so many other factors in an epidemiologic study that can explain this: quality of food, less milk drinking if you drink more diet soda. All of this can contribute to lower bone mass. The higher fracture risk was shown in the Nurses' Health Study. So this is more than 3,000 women from Boston. So that's these are solid data, but they do not prove causality. And then very interesting here, reproductive system. So in girls with higher aspartame consumption, earlier puberty was observed. And early puberty is something that you don't want because it's associated with higher cardiovascular risk. And greater risk of premature delivery, that's really interesting. So a Danish study, the Danes have wonderful registries. So in a Danish study, they just looked in the registry and they found an association between diet soda consumption and early delivery. So the Swedes said, we have beautiful registries too. We check it out in our registry, and they also found this association. And then a study that came from Canada. So infants of mothers who consume artificial sweeteners during pregnancy and lactation have a higher BMI at 1 year of age, and that is corrected for maternal weight gain, and so on. So how is this possible? Here on this slide, I want to remind myself of Barbara Corky, who received in 2011 the highest award of the American Diabetes Association with the Banting Medal for scientific achievement. She gave a beautiful talk. She basically asked, is it chicken or egg? Is it hyperinsulinemia causing obesity, or is it obesity causing hyperinsulinemia? And that goes to your question with regard to insulin resistance, I think. So where does it start? And she argues that potentially higher insulin secretion could lead to obesity. And she looked around in the environment, what has changed in the last 20, 30 years, and she incubated her pancreatic beta cells with all kinds of stuff, emulsifiers, iron, artificial sweeteners. And lo and behold, when you put artificial sweeteners onto your Petri dish with pancreatic islets, they start secreting insulin. Not surprising, they have sweet taste receptors, right? How about adipocytes? So it has been shown that 3T3L1 cells, precursors of adipocytes, differentiate preferentially into, or faster into, mature adipocytes. It's also been shown by our colleague Sabi Sen at GW that, for example, mesenchymal stem cells preferentially differentiate into adipocytes. And I want to, in this cartoon, show you what that might mean. If this were true, that mesenchymal stem cells, upon artificial sweetener exposure preferentially differentiate into adipocytes, that would set the stage. Let's just say a baby is introduced to artificial sweeteners in utero and through lactation to potentially more adipocyte development and less bone development. Early on, artificial sweeteners were praised for their fantastic effect on the being protective against caries because they're bacteriostatic. And so the dentists were happy about the addition of artificial sweeteners in especially chewing gum. But then our colleague Susan Schiffman, early on, before she had the tools of shotgun sequencing, she looked at the microbiome of her rats after exposure to 12 weeks of sucralose, of Splenda. Actually, she took the real Splenda, and a sweet ingredient is sucralose. And so she found changes in the intestinal microflora. She did this with cultures. So this was an early start, but here is the pivotal study that was conducted by Suez et al. So that is Aaron Elinov's group, and I've heard Aaron Elinov only once, but he's dynamite. When you hear him talk about a big subject, and he's not a specialist on artificial sweeteners, he takes on many big topics in medicine. This one here, he showed very beautifully that when you expose mice, so these are just regular C57 black mice, to either saccharin, sucralose, aspartame, he ultimately chose saccharin for most of the studies, then you can see that after 5 weeks, they develop glucose intolerance. They have higher glucose values. And the important point here is where you go from just an observation to really causality is he then took the intestinal microflora of these exposed mice plus the control mice, transplanted this into germ-free mice, and the germ-free mice 6 days later, when undergoing oral glucose, not an oral, a peritoneal glucose tolerance test, they had the same abnormal glucose levels. So I think there is cause and effect, and that was established by this Nature paper in September 2014. So at the same time, we did a little study. We found artificial sweeteners in breast milk, and that had not been known until then. What we did is we recruited 20 anonymous donors, and we asked them to fill out a questionnaire about their artificial sweetener consumption. And then Peter Walter checked for artificial sweetener concentrations in the breast milk samples, and 84% were positive. Also in some of the women who did not report any intake. So because we found this, we asked, what does this mean? So if babies get exposed to artificial sweeteners through breast milk, they obviously absorb the artificial sweeteners just like we do, but they have a lower glomerular filtration rate. Does this mean that their circulating concentrations are higher? Well, we don't do in utero studies. Sweet taste preference. In rats, it has been shown that if you expose them early to artificial sweeteners, they like sweetness better, no matter what kind of sweeteners, when they're older. Microbiome changes, obviously Suez had shown them beautifully, promotion of adipogenesis. So what does this mean for kids? And then while we were discussing this, and we were discussing this with the young scientist who's sitting here on the left, namely Stephanie Olivier van Stickelen, she said, well, I can check this out. I'll check this out in my mice. And that's what she did. And with her results, I want to finish the talk. And since they're not my results, I can say they are pretty stunning. So Stephanie took mice and exposed them during gestation to artificial sweeteners at concentrations that are either at the accepted daily intake level determined by the FDA, so the concentrations that are relevant for human consumption, or twice the concentration. because some of the earlier studies that we have, especially in vitro studies, they were done with concentrations that are really in the pharmacologic range, and you always have to ask, what does this mean? What's the relevance? But here, Stephanie worked with concentrations that are relevant for human consumption. And then she studied the offspring. This here is the microbiome sequencing result of a group of control mice. And what you can see in red are the verrucomicrobia, including, for example, Akkermansia. Then in blue, you see the firmicutes, and in green, the Bacteroidetes. And you don't need any major statistical analyses to see the difference. So here you can see groups of pups that were exposed to artificial sweeteners during pregnancy and during a period of time during lactation. And their microbiome looks obviously different. Now you have done even more analyses in the meantime. So basically, whether the mice were exposed to one time of the accepted daily intake or twice, there's not much difference. They clearly have a lack of the red group, in which Akkermansia is one of the important bacteria. In addition, when you look at the ratio of firmicutes to Bacteroidetes, which is often done as a measure of how healthy a microbiome is, there is an increase of the ratio, which tends to go along with what we observe in human obesity. How about the mothers? Well, I show you the control as well as the exposed at the same time, and it's not impressive. Ultimately, when you look at the ratio, again, of firmicutes and Bacteroidetes, you see something similar, but it's not very impressive. And I think this is what is important. So here again, you don't see impressive results in animals that have an established microbiome, but you see a big result in the pups. So the next question is this basically a toxic effect? Is this a bacteriostatic, at least, effect on the Akkermansia? And when Akkermansia was incubated with, and you can see this in the orange and the red lines, with non-nutritive sweeteners at the lower and the higher concentration, they grew. So it is not a toxic effect directly on the bacteria. It must be an effect on the environment in which these bacteria typically grow. When Stephanie looked at the livers of these pups, she also saw a dose-dependent effect. And basically what you can see here is when you go from left to right, so control to one time, twice, the accepted daily intake of sucralose and acesulfame potassium. So you see that these livers become gradually unhealthy, namely white. And what does that mean? It could mean that it's a fatty liver. That was the first thought, of course, fatty liver. But it's not a fatty liver. You stained the livers, and you did not see that this speaks for a fatty liver. So that one was out. Infection, these animals are not infected. So is it anemia, for example? Is it decreased clearance of, for example, the non-nutritive sweeteners? And you did metabolomic studies, and in fact, all points to a detoxification problem. So there is an increase of reactive oxygen intermediates, and there is a decrease in the excretion and metabolism of the non-nutritive sweeteners, or other products, of course. So to summarize Stephanie's results, artificial sweeteners drastically altered the microbiome of the pups, less so of the mothers. There was a change that is a change that is similar to changes that are observed in humans that are associated with obesity. But the most interesting one was really that the Akkermansia was so reduced, and it appeared to be a result due to a lack of the ability to colonize the pub microbiome normally. The vertical transmission appeared to be normal. So from mother to baby, the Akkermansia was transmitted, but then didn't grow. And there's evidence at these low concentrations. And in fact, again, Peter Walter, with his mass spec, measured, I have to say, so first, you had to milk the mice to get breast milk. And then Peter Walter measured in the breast milk the artificial sweeteners. And they are at very low concentrations. And still, you see this effect. So there's evidence of liver toxicity in pups with evidence for downregulation of detoxification. And with that, I feel it is fair to say that there is no convincing evidence that artificial sweeteners prevent or alleviate obesity. In fact, I have shown you examples of the effects of artificial sweeteners on the microbiome, on insulin secretion, in vitro and in vivo, adipogenesis. This is really something that needs to be further investigated, and the good news is that Sabi Sen is doing this. Less reward. And then, of course, there are other potential effects that I think we need to start looking into, and that's just the beginning. For example, bone and reproductive system. So with that, when somebody asks, what do you recommend? We're always being told, especially by the Office of Public Relations, do not give recommendations. You are just a researcher. So I'm not giving any recommendations, but I've just shown you the data. So with that, I really want to thank my collaborators and co-workers. There's, for example, Ellen Conway and Eileen Ball are right here in the audience, and Stephanie has done a lot of the work. Without the Walters, this couldn't be done, because Mary Walter does all the human assays, and Peter Walter the mass spec assays. So with this, I should also thank my boss. Mark Reitman is sitting right over there because he allows me to do these studies. And with this, thank you.
Thank you very much, Stephanie. That was great. So we have questions, we hope.
I see on your visual there, you have stevia and truvia there. They always say that they're different from artificial sweeteners because they're made from plants. Are they really different or not?
So the stevia plant contains various glycosides, but ultimately Coca-Cola basically focused on riboside A, and that's the one that is in truvia, together with erythritol and a sugar alcohol. So it's more erythritol than riboside, and therefore I think this is mostly an advertisement trick, saying that this is natural. We all know also that many natural things are very toxic. So it's neither natural, whether it's toxic, I don't know. And in addition, there are fewer studies. So I really have focused on sucralose, acesulfame, potassium, and saccharin because the data are there. For stevia, there are really fewer studies.
On the same question, when you see liver changes which you ascribe to detoxification, these are chemically very different materials, and their detoxification would be expected to be different. Was this specific for only one of the items?
So I want to correct myself there in that sucralose is basically not metabolized at all. It's being taken up, only about 20% of what is ingested. The rest is excreted in the feces. So the 10 to 20% are being absorbed, are then excreted via the kidneys. The other one, acesulfame potassium, is also not metabolized, is basically 100% absorbed and all excreted via the kidneys. So whatever metabolites become toxic metabolites and for example, ultimately lead to liver toxicity. These are other metabolites. So it is that the machinery is really altered and therefore leads to toxicity. It is not directly the sweeteners.
When you gave the material and the glucose went up, what was the source of the glucose?
So artificial sweeteners in general only increase glucose transport or insulin secretion when given together with glucose.
Oh,
you need to give them together.
Oh, I see.
I want to mention something that I think is really intriguing, and that is the calcium sensing receptor is very closely related to the sweet taste receptor. And in the calcium sensing receptor, it has been shown that sucralose and acesulfame potassium is an allosteric modifier, so that the message of calcium is increased. So I think that a lot of the effects may actually be that it is due to modification and augmentation of a response that happens anyway with glucose. And the point is that most often we're never really in the fasting state during the day. And so we always ingest artificial sweeteners into a non-fasting body. And therefore it's artificial sweeteners with glucose.
So the most important thing is to study the binding of these artificial sweeteners to the ligand or receptor, whatever in the cell. You mentioned they are interacting with the glucose receptor in the enteroendocrine cells. Is it true? Is it well established, studied properly?
One point is very important, namely that animals that were knockout animals for the sweet taste receptor had sucralose-induced effects. So sucralose, for example, must mediate its effects in also an sweet taste receptor independent way. That's one thing. So I think to just focus on the sweet taste receptor would be an oversimplification. Also, when you think of the microbiota, I don't think this is bacteria, the response to sweet taste receptors. This is the direct effect of these bacteria taking up the artificial sweetener. So these are sweet taste receptor independent effects.
What is the dose you have given? Is it something similar to what we are taking every day?
Yeah. So we try to do these studies, and we had long discussions. For example, in the branch meetings with Mark, we have long discussions. Should we max out the doses and go to the allowed doses, the upper limit, or do something, what we have done, we give a diet soda. So this is way below the accepted daily intake. And still we see effects. So I feel it's important to really look at the whole range. And as you could see in the pups are exposed, most pups, exposed to very little artificial sweetener, and they have these major effects.
Well, that prompts a question. Do the artificial sweeteners cross the placenta?
Mm-hmm. So we want to work with our colleagues at Walter Reed in order to get some specimens, amniotic fluid specimens from women who undergo elective C-sections. And we're in the process of working on this protocol. But in the meantime, looking at data from animals, so acesulfame potassium as well as saccharin had been shown to do that. And actually, Stephanie made me aware of some data on sucralose too. So yes, they appear to cross the placenta.
So what is your explanation for why the bacterial population in the gut of the newborn, you say, receives very, very little of these things through the milk, and yet at the time they are born is when you measure this
so
in a short time.
I should clarify this. What we have done is we exposed the mothers, we looked at the newborns, but specifically the microbiome analyses, metabolomics and so on, was done at 3 weeks of age. So these animals, the little pups, they were 3 weeks old, and that's the time when they stop breastfeeding. So they had the whole exposure during pregnancy and during the lactation. And what Stephanie has done is she looked very early, and very early, the newborn pup looks just fine. There's no difference. But when you look at the continued exposure of these pups, and it's very interesting. So the development of the normal microbiome in pups and humans has been studied, and there is a truly explosive growth of a variety of bacteria with aging individuals. So the normal microbiome in a human is established between 1 and 2 years of age. So within the early months, there's a small variety, then it gets larger, and the same thing, of course, in a shorter time frame is true for the animals, for the mice. So, but the question, I can't answer it, namely, what exactly is it in the intestine which does not allow a normal colonization? What we know what it's not is it's not a direct toxic effect.
I have a question that may be to both of you that you may want to tackle. You showed some of the very nice PET studies, a response to sugar and response to artificial sweeteners. We know from other studies that addiction, and including different other types of addiction, including food addiction, depends very closely or relates very closely to activation of nucleus accumbens and some of the other parts of the brain that you showed. And I don't know if any of you have had a chance to take a look at whether the artificial sweeteners and food addiction go together, or has any difference?
I basically need to declare ignorance based on my own results. Now, the good thing is we have Lorenzo Leggio in the audience, so maybe Lorenzo wants to say something about addiction, but I think at the present time, it's premature to talk about addiction with regard to artificial sweeteners. But Lorenzo, so I didn't put this into the talk, because one very interesting finding is that in various studies, when you give artificial sweeteners compared to sugar, ghrelin is not equally suppressed. So that was one mechanism, and here's the specialist on ghrelin and addiction. So
yeah, I don't know if there is anything on addiction. So patients with addiction, we study primarily alcohol. I don't think there is anything on artificial sweeteners. And in patients with alcohol substance use disorder, there is something on the sweet preference and addiction. Actually, right now we have a paper under review, but also UNC, Alexei Campo-Polivoi, Janina Pepino, who works with with Kristina, they have shown that sweet likers seem to have a higher risk of developing alcohol use disorder. So more precisely, like Janina Pepino showed that the sweet likers have a higher, basically, history of a family history for alcohol use disorder. And also, one of the medications that we use in clinical practice, naltrexone, which works on the opioid receptor, and it's approved by the FDA. There are two studies, one on JAMA Psychiatry recently from UNC, showing that the sweet likers are better responders to naltrexone compared to sweet dislikers. One question mark, which that's what we are trying to pose in our paper, is how we define sweet likers versus sweet dislikers. So actually, we applied a sort of heat map approach, and based on the cutoff we use, actually the definition could vary the profile of the patient. So that's as much as we know, I think.
Thank you.
Thank you.
You can talk later with them. Just rotate a little bit.
I'm sorry, this is probably a question for both Dr. Gorden and for you, and that's about the role of insulin and things in the brain and Alzheimer's, and if artificial sweeteners have the same effect, what is the effect with Alzheimer's?
Now, I think this is a superb question, but I would, at the present time, take it as an idea to be studied. with regard to artificial sweeteners. So I don't think there's any evidence, but I feel it's a very important question.
No, I would have to say the same thing. I think that the issue of insulin effect in the brain is sort of a work in progress. It's an interesting idea, but I think that it's not quite mature enough to really say very much about, at least from my perspective.
Okay, well, if there are no other questions, I want to thank you. One more.
If you stop the artificial sweetener, do we get our bacteria microbiome back?
So if I was Susan Schiffman, I would really say this is a staged question, because she's done this. She looked at 12 weeks of exposure of her rats, and then she stopped the exposure, and she looked again 12 weeks later, and there were still changes in the microbiome. So they had not reverted to normal. Do I know that this is the case in humans? No. Yeah.
All right, well, thank you again,
Thank you.
and thank you all for coming.